Uh, Now this is the time for session 3, and this session will be speeched by two of our international speakers who are very renowned, and this session will be chaired by two of our legendary professors. One is Professor Bilal Alam sir, former professor, principal, Sir Solimullah Medical College, and acting as controller of examination, BCPS, Bangladesh College of Physicians and Surgeons. And another one is Professor Shafiqul Alam sir, a legendary neurosurgeon in Department of Neurosurgery, Dhaka Medical College Hospital. I would like persons to please us, and we'll be starting our session in very short time. Our first speaker is Professor Hong Tao Hu. He is a chief.
Come from Henan Cancer Hospital. I will share my slide now. Can you hear me?
Yes, sir. It is clear. You please continue.
Okay, thank you. So as we know, the hepatocellular carcinoma is one of the most common malignant tumors in China. The single tumor larger than 5 centimeter, we call the large HCC. In our country, only 20 to 30% of the patients with the large HCC are a candidate for surgery resection or only to the ablation therapies. So as we know, the TIS has been recommended as an important treatment method for large HCC because most of the patients can benefit from this kind of treatment. So we will face this problem. How to reduce the tumor residency and the recurrence is our working. Finally, we would like to bring survival benefit from each kind of treatment for the patient. But this kind of question, they have still no answer. So they have different options about the effect of therapy on large HCC, except the surgery, such as the TIS. Some doctors, they think the TIS is the best treatment. Also, some doctors, they think the hike is more effective for the large HCC. And also some Chinese doctors, they think using the ablation by 2 or 3 microwave ablation treatment will the best results. But there's still no right answers. So today I would like to talk about 3 key points about the large HCC treatment. The first is how is we should use TIS or ablation alone or combine together. The second point is when. If we want to use the TIS combine with ablation, so the appropriate time, combine time is should be explored. The third is the which. So which kind of TIS should we use, the CTIS or DTIS? As we know, a study involving more than 10,000 patients received TIS, showing that a 5-year survival rate was 32.4%, and the median survival time was 19.4 months. Yun reported 65% of patients could benefit from the TIS, and the median survival time was 15.8 months. Also, they also reported after the TIS, the surgical or local ablation was an important factor. This kind of treatment will affect the survival of patients. So most of patients, if we can receive the surgical or ablation after the teeth, so they can get more the longer survival time. So that's why only teeth is difficult to achieving a cure effect. This is, everyone knows this, but the repeated teeth treatment can lead to severe liver damage in patients, such as the liver function, even more complicated complications. So ablation therapy also used for the large HCC, and they can cooperate with teeth for further inactivity residual lesions and completed cure tumors. So another important reason is ablation can reduce the use of teeth embryologic agent such as lipiodol or microsphere. So this kind of method can avoid such severe complications. So we think ablation combined teeth is better than alone each method. So Takaki has been reported that the RFA ablation combined with teeth in 32 patients. There are 20 patients with large HCC and 36% tumors could be completed inactively by several times ablation. The research has had a good result. The 1, 3, and 5 year survival rate were 100%, 62%, and 41%. As we know, even the small tumor, the early stage HCC, the 5 years survival rate is 40% to 60%. So this result is very good. The 1, 3, and 5 years recurrence-free survival rate was 74 and 28% and 14%. So another doctor used microvalve ablation combined with teeth to treat the large HCC with sclerosis. A total of 84 patients were included in this study. So the first treatment of tumor by microvalve ablation and then performed the teeth treatment within 1 month. So this is a very short time between the two kind of treatment. So the results showed the 1, 2, and 3 year survival rate was 91%, 68%, and 49%. And the survival or local recurrence rate was 25%. Let me show you some case. This is a man with large HCC. He got the treatment from our department. This is a patient underwent the teeth, and 2 weeks later, we give the first time ablation for the segment 8 segment lesions. Here you can see the ablation. We use the microvalve ablation, and second time we do the 6 segment lesion ablation. Here you can see the MR showed the no tumor activity. So the patients get a good result. The OS is more than 10 years, and now he's still alive. And the second case is not so big. It's just 8 centimeter liver cancer. Also, he underwent the teeth first, and then 1 month later, he underwent the ablation. We also using the microwave ablation after the teeth treatment. So 1 month after, this patient underwent the radiography ablation, RFA ablation. The patient follow-up image or MRI showed the complete ablation and no tumor activities. This is almost 4 years later after the RF ablation. The MR also showed has a good result, and there was no tumor activity and showed the complete ablations. So the second is the one that's sequential or simultaneous. The teeth combine ablation sequence in a short time is recommended for a small HCC. There are many reports and they get this kind of conclusion. Retrospective study, 43 patients with large HCC, and in this kind of patients, 16 patients had tumor achieved CR after 1 treatment. That means they using the teeth first and then give the ablation. So they get almost 40% patients can get the CR, just one procedure treatment. So other patients in this study achieved a 90% inactivity of the tumor, just underwent 1 treatment. So this is showed the sequential treatment is also a good method. So for the simultaneous treatment method, the procedure is the patient underwent the angiography first, and then the patient go to the was moved to the angio room and give the ablation, move to the CT room and give the ablation, and then the patient underwent the transartery embolization. So using this method, after the ablation, we can reduce the amount of embolic agent and reduce the liver damage. So the first complete ablation rate was 90%, and the 1, 2, and 3 year survival rate was 96, 87, and 74. So let me show you the first case. Here you can see a big tumor, HCC, and the patient underwent the microablation first, and this tumor get most of the tumor was ablation and no activity. Here you can see after the ablation, we perform the angiography. Here you can see that there's just a small blood supply from the hepatical artery. So after the angiography, we give the embolization using a lipoidal. Here you can see we just give 7 lipoidal, and then the tumor get a good result about the embolization. Here you can see 1 month later, we using the MR scan to follow up. So the MR image shows the complete inactivity of the tumors. This is the second case. The CT shows that the diameter, the tumor diameter almost 10 centimeters, and had a good, great blood supply. Here you can see the angiography. We perform the angiography firstly, and then the patient underwent the microwave ablations using different direction puncture. After the ablation, we perform the angiography. Here you can see that was from the hepatic artery. We can't see the tumor supply arteries, but the phrenic artery showed that still have the tumor supply. So we give this artery embolizations. Here you can see 1 month follow-up. The MR scan showed there was no activity tumors. And this is 10 months follow-up. There's still no activity tumor, and the ablation combined with the teeth had a good result. And the third point is which kind of teeth is better, C teeth or D teeth? So teeth is required large dosage of embolization materials, such as the lipiodol, microsphere, or some other materials. But a large doses of the embolization materials can increase the risk of liver failures in patients. Actually, 20 years ago, when I was a young doctor, I also using a large dosage of lipiodol to treat the patients, because at that time we haven't this kind of such as microsphere, this kind of embolization materials. I remember is the biggest dosage we also using 50, more than 50. So the patients, the liver damage is very serious. So the damage of the large quantity lipiodol on liver function was greater than that of microsphere, because some doctors, they think the lipiodol is not only is not the real embolization agent. So using the microsphere is safety than the lipiodol, especially when we using a large quantity embolization materials. So the embolization effect on different, but the embolization effect, there was no difference between the lipiodol and the microsphere. Even we using many patients, we can't see the microsphere is better than lipiodol for the OS. I'm not mean the complications. It's just for the OS. Maybe this kind of two embolization material is the same. So for these patients, here we can see after the 2 times of CTs, the tumor is decreased, and then he underwent the ablation. Here you can see this is the 5 days after the teeth and tumor ablation, and this 2 picture is the 3 years. I remember it's 3 years. Yes, 3 years after the teeth combined with the ablation. Here you can see there was no tumor activity, and the tumor size is decreased. And for these patients, we can see this tumor is more than 7 centimeters, and also has a good artery supply. And here you can see the patient underwent the DTs. After the DTs, we can't see the tumor artery supplies, and also this patient underwent the microvalve ablations. So after the 3 months, of the teeth combined with the tumor ablation, we can see the MR follow-up image showed no activity tumors, and this patient got the CR effect. So as we know, nowadays, more and more new method to treat the HCC has been developed. The immune checkpoint inhibitors and the TKI oral medicines has been widely used in the world. So the mini-invasion interventional therapy is the base, but the ablation and TIS is the base of the mini-invasion treatment. So this kind of therapy can significantly reduce the tumor activity and reduce the tumor resistance to the target drugs, playing a significant therapeutic effect, especially for some patients if we can't get the benefits from the target drugs. So they also can get the good result by using the TIS or ablation therapy. The combination of the PD-1 or PD-L1 after the ablation can effectively inhibit tumor immune escape and improve the efficiency of ablation-induced immunotherapy. So I think this is the future for our treatment. So in conclusion, the TIS combined ablation can significantly improve the patient's condition and prolong the survival time. Also, if we can need aided the target medicine or giving the PD-1 or PD-L1, I think the survival time will be for a long time. According to the characters of each patient, the appropriate how, when, and which should be selected. As we know, different patients has different conditions, so we can't say we do the TIS combine ablation together in one day or is good, or the two methods has some days or 1 week or 2 weeks prolong, that will be better. I don't think so, but we should according each patient. Each different patient has different conditions, so we give the different treatment. So that's we thought is the personal treatment strategy. Another is the combination of target drugs and immune checkpoint inhibitors may achieve better results. So ablation will play a increasingly important role in large HCC. Of course, whatever microwave ablation or RF ablation is also do the good works, but for the large HCC, the microwave ablation has its advantage, such as the rapid heating, a wide ablation range in the short time, and no thermal dispersion effect. So for these reasons, I think the microwave ablation has the advantages for the large HCC ablation compared to RF ablations. Thank you, everyone.
Thank you. Professor Hong Tao Hu had a very good, well pictorial presentation for us, and we had some experiences regarding TES and RFA. And we are very delighted to inform you that we have another chairperson in the dais at present. Professor Khan Abul Kalam Azad, sir, is here with us. He is the acting principal of Popular Medical College. So we should go to the next session, that is on TES and TEAR in hepatocellular carcinoma. And that will be presented by Shubho Roy Chaudhuri, who is a renowned intervention radiologist and is working in a very reputed hospital now, that is super specialized Narayana Hospital. And he will be with us for the next session, that is TES and TEAR in HCC.
Before Professor Shubhra Rai starts his before Professor Shubhra Rai starts his deliberation, I'd like to say something about Professor Shubhra Rai Chaudhary. And he's a very good friend of mine and also a very good friend of Bangladesh and very good friend of all my colleagues who are involved in TASE. And actually, we are now doing, our team is actually doing TASE regularly in Bangladesh. This is due to contribution from Professor Shubhra Rai Chaudhary. He first started doing TASE and gradually trained up some of our boys who are now doing independently TASE. So I congratulate and give my thanks from myself and my association and on behalf of my country to Professor Shubhra Rai Chaudhary, who is a very renowned interventionist in India and also in UK. Thank you. Thank you all.
Professor, thank you very much, and it's a great pleasure to come and speak to you here, and also in the 3 or 4 times a year visit to Bangladesh. The forefathers came from this land, and therefore there is a connection, and we speak the same language, so it makes it almost like home. So it is always a great pleasure, and thank you to Professor Salimur Rahman and Farooq for this kind invite. So Prof has asked me to speak on TASE and TARE for HCC, when, how, and which. So it's quite a wide area to cover, so it would not be possible to delve deep into the literature. So, but I just quickly wanted to go through the basics. I need my glasses. So we all know the revised BCLC classification system from EASL from 2022. As we know that there are some changes. We know that BCLC A, B, C, and D. BCLC A is the early, very early or early, then B is intermediate, C is late, and D is a very late disease for which we don't offer any sort of either interventional or systemic therapy. We only offer best supportive care. So the basic changes that has happened is, as you can see, the blue line across the middle of the screen is that the survival times for each of these groups have increased. The second important thing that has happened is this concept of stage migration. So but by that we mean that we don't stick to one particular treatment algorithm. We always are dynamic and keep on changing our thoughts regarding what do we do with the patient based on a patient's response. In other words, if a patient responds very well, we move towards the left-hand side of this algorithm. If the patient does not respond, then we move on towards the right-hand side of the algorithm. So that is one key aspect. The other key aspect that has changed in the new algorithm, of course, is the bottom right corner of the screen is the addition of some oral chemotherapeutic drugs, several of them, and I'm not going to list them, several of them, and that includes immunotherapy, which has drastically and significantly improved survival in patients with advanced HCC. And the other thing that you have heard the gentleman speak just before me, and you have heard Professor Soin speak before the tea break about the concept of combination therapies, about the concept of 2 + 2 making 5 rather than making 4. So this is the key concept in current thoughts of HCC. I'm not going to go into exactly how do we deal with each subset of liver classification. So coming to transarterial embolization, there are 4 groups. There is a bland embolization without any chemotherapeutic, that is as practiced in Sloan Kettering. They claim that the results are as good as TASE, although it is not universally recommended. Then we have conventional transarterial chemoembolization, that is mixing an etherized oil called lipiodol with doxorubicin, epirubicin, etriamycin, cisplatin, mitomycin C in various protocols, and in which a emulsion is made, which is injected, which is taken up by this tumor. So we'll talk about that. Then you've got chemoembolization with drug-eluting beads, which are particles of a defined size, 100 to 300, 300 to 500 microns, onto which doxorubicin or irinotecan can be loaded, and that can be delivered into the tumor to deliver a high kill dose locally to the tumor without exposing the patient to the systemic side effects of chemotherapy. And then you have transarterial radioembolization, which is a similar concept, but it is not an embolic, it's a microembolic, which means that the particles are going and not blocking the blood supply, but delivering beta radiation to kill the tumor within 2 to 3 millimeters of the particle. So these are the various transarterial loco-regional therapies that we have at our disposal. Now if you look at intermediate HCC, which is the middle group of BCLC, is a very wide group, right? You can have a tumor which is more than single tumor more than 5 centimeters BCLC, and you can have 25 tumors occupying 60% of the liver also as BCLC-B. So there is a problem in substratification within this group of BCLC. So TACE is the standard of care for this group. That's what EASL says. That's what most of the medical societies say. It should be delivered as selectively as possible. However, the problem is that protocols are not standardized. We can have debate about drug-eluting bead versus conventional TACE. Then we have selective internal radiation therapy or SIRT or TARE, or we can have various combinations. Now, this is a very important paper that came out about a couple of years ago from Taiwan, I think. And what this paper talked about is the fact that when you select a patient for TACE, it is very important to stratify that patient based on this criteria called the 7-11 criteria. Now, what does the 7-11 criteria mean? The largest size, the size of the largest HCC plus the total number of HCCs. That is the number that you want to get. Now, if that number is less than 7, TACE is very, very good. If the number is more than 11, TACE is very, very bad. If it is between 7 and 11, then it is intermediate and you can think about doing TACE. Now, I do work with professor in Bangladesh, and I, as a proctor, and what I would like to say is that here most of the patients belong to the beyond 11 criteria. Do we not do TACE? Therefore, we do, because the other options are not really available. So, see, these are all great things. The 7-11 criteria is something that you should try to adhere to, but we work in difficult economic circumstances. We work in circumstances where there are other logistical issues. So you need to think about those things when delivering care. So if you look at the guidelines from 2014, and I must say that these have changed. So multinodular asymptomatic tumor BCLC-B without vascular invasion TACE is the standard of care, and bland embolization is not recommended. This is the standard ESMO guideline, but these can be debated. Now, the other important trial that came out was a European trial called the Precision 5 trial, which compared drug-eluting bead TACE to lipiodol conventional TACE. Now, I had a speaker from China just previous to me. If you go to Korea and Japan, and they would swear by what we call conventional lipiodol TACE. They would use it for small tumors, they would use it for large tumors. This is a study from Greece, Germany and Europe, and in which they showed that the overall survival between the two techniques are same, but the side effects of drug-eluting bead TACE are less. So I will tell you how I use that in my patient selection algorithm. So when I choose my patient for TACE, BCLC-B, few cases of BCLC-A. A small tumor, I can get super selective, I cannot do ablation for some reason. Patient is not suitable for resection for some reason. We can consider doing an ultra selective TACE, and I'll show you pictures of it. And few cases of BCLC-C. Yes, the liver function is not good or the tumor is advanced. Liver function has to be between child A and B7 at a push B8, not beyond B8. But suppose the tumor is a little bit more than that. It is a BCLC-C, segmental portal vein thrombus. We can still consider doing TACE. Performance status is really important. We should not take patients who are PS2. Well-preserved liver function, like I said, child A and B7. Less than 50% of liver involvement, alpha-fetoprotein less than 20,000, limited extrahepatic disease, difficult to define, right? One lymph node which looks suspicious is okay, one tiny nodule in the lung is okay, but two regions of extrahepatic disease, let's say one node and one lung nodule, not okay, because that is metastatic disease and that is not something that you should consider TACE for. No major portal vein thrombus. Subsegmental or segmental portal vein thrombus coming up to the main portal vein but not involving the main portal vein. We call it VP1 and 2, but VP3 and 4 is not an indication to do TACE routinely. We can modify, of course, we can combine it with SBRT, etc. But I'm talking about in general, that is not a patient to be considered for TACE. The other things that we miss out when we select patients, white cell count less than 3,000. Be careful, because doxorubicin does cause bone marrow suppression. Cardiac function less than 50%, be careful, because doxorubicin has got cardiac side effects. So use an alternative agent like cisplatin if you have got things like that. So these are important things to consider. Always remember to try to downstage a tumor if you can, because transplant, I am not so enamored by resectional surgery, because with resectional surgery you still have the liver left where new fibrosis, new tumors can develop. Whereas transplant, on the other hand, is treating two diseases at the same time. It is treating the cirrhosis and it is treating the HCC at the same time. So the goal is to get the patient to transplant. If you can downstage the patient to transplant, that is the goal. However, finances are important, patient fitness is important, convincing the patient is important. So all of these are important criteria. But use the 7-11 criteria, the ALBI score, etc. So this is a case in Bangladesh from a long time ago, actually. I think it's about 5-6 years ago. Exophytic tumor, risk of bleeding. These patients, even if the liver function is borderline, I would go and treat, because this patient has a risk of bleeding and hemorrhage, and that is a bad prognosis in patients with HCC. So treated successfully with a selective catheterization. So the basic kit that you need, and this is, I must admit, if I say this to you guys, that the main difficulty I find when I come here to do, to decide on cases is the imaging. The imaging needs to be state of the art. The CT, the MRI needs to be state of the art. The triphasic imaging, the visualization of the portal vein needs to be state of the art. You need to see arterial phase enhancement, washout, capsule, all of these criteria that are described along the LIRADS classification. We need a good quality pre-op angiography. We should not be deciding on the vessel anatomy at the cath lab. We should know what vessel anatomy there is before we go to the cath lab. And then we need kit, we need good quality kit, we need microcatheters. We need basic microcatheters to do segmental level embolization, and we need very fine microcatheters, 0.20 of an inch, very, very tiny catheters that can go to subsegmental level for finer microcatheter. Then we need to use the lipiodol in the correct technique. Lipiodol needs to be mixed with doxorubicin. It should be water in oil, not oil in water. The doxorubicin should be pushed into the lipiodol and not the other way around. The ratio should be about 3:1 to 4:1. And the last thing that you need is a cone beam CT. And I think to do a TACE without cone beam CT is a little bit difficult. Cone beam CT has several advantages, and I'll talk to you about this. This is a paper from Thailand actually, and that shows that actually there is an improved survival in patients who are done with cone beam CT. You can see the two Kaplan-Meier curves diverging. So here is a typical case from day before yesterday, so hot off the press. So here is the arterial phase, here is the portal phase, you can see venous phase, you can see the washout, well capsulated, rounded tumor, right? Here is our celiac angiogram. We would do a CBCT from this point to see the vascular feeders. Then this is, if you are going to do a lobar TACE, this is where our catheter position is. So it is into the right lobe artery, but this is not good enough. So we have now put in a microcatheter to go further forwards. You can see the microcatheter further forwards into the tumor, into a subsegmental position. And this is a more or less a super selective position, or not super selective, still a selective position, not ultra selective. Ultra selective would mean that I need to get into that upward looking branch. So here is the lipiodol being given, and you can see the lipiodol uptake, and you can see the tumor has now gone, and here is the lipiodol uptake. Now can you see on the lipiodol uptake that there is a defect in the lipiodol uptake at about 1 o'clock? So this would mean that there might be another vessel that is coming and supplying. And here is the advantage of cone beam CT. If you had a cone beam CT, if you do a cone beam CT, we'll show that in a second. So this is a cone beam CT. And you can see that actually there is a little bit lighter uptake in that upper corner, but we know that there is another branch that is coming, but we had exhausted our lipiodol. We are going to come back and treat this patient a second time. So the advantage of cone beam CT is to assess the blood supply, to assess completeness of TACE, whole tumor has taken up, to assess non-hepatic feeders like the inferior phrenic artery, very rarely the left gastric can supply a hepatic artery, to assess for non-target embolization. So these are the reasons you need to do a cone beam CT. And here is another case again from last week. These are cases from Kolkata. So you can see that there is a small tumor in segment 2 of the liver, and there is a slightly larger tumor in segment 6 of the liver. You can see the arterial phase enhancement. Now here is the hepatic angiogram. Can you see the uptake? Here is the uptake of the, I'll play that again. Here is the uptake of the tumor, the first tumor and the second tumor here. So now we have got a catheter into the selective position. We can see the tumor uptake. Now we have got a microcatheter right inside. So this is what is called an ultra-selective position. So we are delivering the drug only into the tumor and nothing else. And here is a nice ball that you can see because of the lipidal uptake. And you need to see this very nice ball of uptake. So then we go to the left-sided tumor. Here is the blush. And you can see that we have taken a very fine microcatheter. This is an Asahi microcatheter right up to the tumor feeding vessel. And look at the dense lipidal uptake that we see. And the other important thing that we need to see is early portal vein opacification around the main tumor. So that indicates completeness. That's a Japanese technique of showing the portal vein as a completeness of TACE. So that is the end point of a TACE. So I'm not going to go through these very difficult cases of inferior phrenic cannulation. We cannot cannulate, so we can do something called coil protection. We can coil the inferior phrenic so there is flow diversion of the drug into the right inferior phrenic, and then you can go and you can see the uptake into the right inferior phrenic. So these are slightly advanced cases. This is a custom side hole made in the catheter because you cannot cannulate the inferior phrenic artery. So you can see this again, a little bit of residual tumor from a previous TACE, and the inferior phrenic is very difficult to get in. We cannot get in. So many catheters have been used, look, and we still cannot get into the inferior phrenic artery. So what we did in this case was make a hole in the catheter and then get the microcatheter through the hole to get into the inferior phrenic artery. So that's the joy of doing intervention, is that you need to think on your feet and make plans accordingly. So then we were managed to get inside the inferior phrenic and embolize. You can see the cone beam CT corresponding to the area of residual tumor. So that brings me to transarterial radioembolization. I'm not going to spend as much time because I must admit that I don't do as many tears as we do TACE, and that is mainly down to economic grounds. It is not because of the reason of clinical science, because transarterial radioembolization has come of age. It is a very, very effective technique if used well, particularly if high dose radiation is given to the tumor. So it can be done by using resin or glass microsphere. So traditionally it was a lobar or a whole liver treatment in a palliative setting for advanced HCC in patients who were not fit for, not suitable for anything else. But recently there have been a number of evolutions. I think Dr. Soin briefly touched upon that in terms of downstaging in his latest study. But it is a microembolic. It preserves the vasculature. It doesn't cause ischemia. So it is therefore suitable in patients who have got portal vein thrombus. And it kills by radiation effect rather than by embolic effect, by beta decay. And the other concept that is important is this atrophy-hypertrophy complex, which means that you can use radioembolization as a modality to hypertrophy the contralateral lobe, the lobe that you are not treating. Instead of doing portal vein embolization, you can use radioembolization because it is killing the ipsilateral tumor and causing hypertrophy of the contralateral lobe at the same time. So it is usually a two-step procedure, although in the West now a one-step procedure has started as an outpatient basis. And so here is a case from Medanta, actually brought to by my colleague Rohit, who's now currently works with me. So there's a common trend of people from Medanta learning liver. They do liver very well, and they come to us to do vascular. So it's been this is number 3 now, Dr. Soin. So Rohit brings in wonderful skills regarding liver to us, and we teach him some vascular skills. So it's a win-win for both of us. So here is a case from him. Really, as you can see, it's a very extensive case, extensive HCC. We would not normally consider doing anything for this patient, right? We would send the patient for best supportive care. Large tumor, 16 centimeter, 19 centimeter, portal vein arterialized thrombus, and those are the venous phase. You can see the washout, and the portal vein arterialized thrombus is up to the main portal vein. This is the coronal picture. You can see that, you can see the extent of the tumor, right? So this patient had a common hepatic artery angiogram, then had a surrogate feeder from the inferior phrenic artery that was embolized to redirect the blood flow from the hepatic artery. Then a scintigraphy was done, dose calculation was done, and a shunt fraction assessment was done. You need to make sure that there is not much radioembolic going to the lung or the GI tract. Okay, so we need to know these percentages. Less than 20% to the lung, less than 5% to the GI tract. Once you have those numbers done, then you deliver the appropriate dose. Now I must admit that this is probably 2015, 2016. Today this dose would be much, much higher than what it would have been in those days. But even with those doses, you know, like look at the result of the necrosis of following transarterial transarterial radioembolization. We can never achieve this sort of results with TACE. So again, pre-tear and post-tear, fantastic results. So this is a very recently published randomized study now, small study, less than 100 cases, but randomized study between tear and TACE. And if you look at this study, it clearly divergent Kaplan-Meier lines showing that tear is superior to TACE when it comes to BCLC-B and BCLC-C. So I think we need to encourage more people to do towards tear because the side effects are less, you can see the adverse effects are less, mortality is less, 30-day mortality is less, and conversion to surgery and transplant is higher with tear than TACE. So if you ask me to compare, today what I say to my patient is, if you don't have to sell your house to do a procedure, then please do a tear. If you have to sell your house, then please don't. But otherwise, it is preferable to do a tear. So if you look at meta-analysis, and this is going back to some old studies too, overall survival, yes, there is no difference, but certainly time to progression, tear is superior. And the current thoughts on tear, these are very important concepts, you know. What you can do is you can do a radiation lobectomy. So you can go and deliver radiation to one lobe of the liver so that it shrinks and the other lobe becomes big, which can subsequently be resected. So this is lobectomy. You can consider doing a radiation segmentectomy. So you can go segmental into the tumor and deliver a very high dose. And that is actually as good as resection. And I think the surgeons will also agree that they are not even needing to resect that segment because the tumor is completely disappearing. And then this concept of modified radical where you give a high dose into the tumor and a lower dose into the lobe. So a bit of both worlds. So these three are the evolving technology for tear. So after having spoken to you about all of this, how do I decide and triage when a patient comes to you in a clinic and is sitting across the door, across your table? So first thing I would like to say is that you need to encourage combinations. Can you combine TACE with ablation? Can you downstage it to surgery? Can you, sorry, not surgery, can you downstage it to transplant? Can I combine it with lenvatinib? Can I combine it with sorafenib? All of these thoughts are always going through my mind. Within that segment, if it is a small 3 centimeter or less lesion, not for surgery, not for ablation, the lesion is hypervascular, then I would do an ultra-selective TACE, C-TACE. Conventional TACE, ultra-selective. If the lesion, single lesion up to 7 centimeter, hypervascular, I would do a C-TACE followed by ablation, as you heard the previous speaker say, combining. If the lesion is up to 7 centimeter but hypovascular or infiltrative, C-TACE is not so great. So I will do a depth TACE or I will do a tear. If the total number of tumors is 5 to 11 centimeters, so I said the 7-11 criteria, no PVT, I would do a depth TACE, not a C-TACE. So bigger tumor, infiltrative tumor, older patient, poorer liver function, I would do a depth TACE. If it's a smaller tumor but a child C, I would consider an ablation, depth TACE or a segmental tear. If the tumor is greater than 11 centimeter, I would consider a tear, not a TACE. If a tumor is a small tumor with portal vein thrombus, I would consider an ablation along with SBRT or a radiation segmentectomy. If there is a large tumor with portal vein thrombus, I would consider tear with SBRT. Tear plus minus SBRT. So in other words, there is a guideline, there is a patient, and there is you. At the end of the day, you need to make the call based on the guidelines, but based on the available evidence, what the patient can afford, what your setup can afford, and deliver the best possible care for the patient. So I would not be able to give this talk without the people here. The team is much smaller than the picture showed by Dr. Soin, but nevertheless it is a team. The operating word is a team. Thank you very much for your attention.
Thank you. Professor Dr. Shubhra Rai Chaudhuri, a true friend of Bangladesh and hepatologist, for your excellent, elaborative, and sophisticated speech. What we have actually come to know that for HCC management, we need a very good teamwork that includes transplant surgeon, hepatologist, as well as intervention radiologist. So now is the session for discussion and question answer. If one or two questions can be asked from the audience. The microphone is in the back side. You please.
I have a question for Professor Hu. As he told us that combination treatment of TACE and microwave ablation is best for the giant tumors. So which one is better, TACE after microwave ablation or microwave ablation after TACE?
Whether first speaker is available or not in.
If Professor Chung is not, oh, there he is. Sorry, yeah. Professor Chung, did you get the question? Hello.
Hello, Professor Hong, are you online?
Sure, I'm online.
Yes, we had a question from our participant.
Yes, I have been give the answer. Did you hear me?
Yes, we can. Yes, we can.
Yeah, just now he asked me about the sequence of the ablation and the embolization, right?
Yes.
Yeah, I think so.
Yes.
Sure. I think in the most of the case for the large HCC, we do the sequences. First we give the ablation and then we give the embolization. But for the small HCC, I think at the same day or do the two procedure within 1 week is better than for long time intervals.
Thank you, Professor Hong.
Thank you very much.
Thank
you very much.
Any more question from the participant?
Can I put another question to Professor Hu? Sir, which chemotherapeutic agent do you think is good when you combine microwave ablation with TACE?
Excuse me, can you repeat the question?
Which chemotherapeutic agent is the best for combination of TACE and microwave ablation?
Actually, most of the time we using the Leopoldo because in our department we using the CT guidance. As you know, for the CT guidance, the Leopoldo has a good image for the direction, and also we can using the Leopoldo can deliver the energy to the surrounding liver organizations. So, but for the liver, but for the large HCC, I think if we can use the microsphere, that will be a good decision, because too much lipido can damage the liver function.
Thank you very much.
Thank you,
Thank you.
Professor Hong.
So I have a not question regarding situation to Professor Shubhra Rai Choudhury. We are very delighted to have you here. In most of the occasions, liver cancers are multifocal based on the injury caused by B virus association, and there is some serotic change along with bleeding manifestation. What is your exact idea to start, as because lot of weapons are there to fight against HCC? But what is your personal insight? How you will be starting with multifocal issues based on B virus association with some bleeding tendency and ascites? Your starting moments with such patient.
So if the patient is decompensated beyond child B7, then transarterial therapies are not great because you're compromising liver function even further. If the patient has ascites, then ablation is also not great. So the problem becomes when the patient has got ascites. If the patient has got ascites, then if the patient is within Milan, expanded San Francisco, or even the further expanded criteria, because of the liver dysfunction, because you are going to treat both diseases at the same time, I would see if transplant is an option. If that is not the case, because of whatever reason, finance, etc., logistics, not an issue, not a case, then we would try to not do a transarterial therapy. If I have to do a transarterial therapy, it should be more towards tear rather than TACE. But you know, certainly I've seen the example of the gentleman sitting next to you. Even very large tumors have been treated by ablation as long as the ascites can be safely managed. So maybe you should drain the ascites, you should plug or burn the tract along which you're doing an ablation so that your bleeding risk is decreased and minimized. That is the way we would do. We would not want to do TACE in somebody with a frank child C. We would not.
Another question for Professor Shubhra. So you talked about the 11 centimeter tumor, that tear is the treatment of choice. But as you know, in Bangladesh, we don't have tear and it's very expensive, and I think 98% patient cannot afford it. So what could be the alternative?
So that is the case even in India, that most people are not able to afford a tear. So I must admit that the cost of tear is decreasing, and actually now we have got a system whereby we can actually treat 2 patients with a single dose. I don't know whether you're doing that in Delhi or not, Professor Soin, but it is possible to treat 2 patients with the same dose because the dose can be made larger that comes in. So if you can organize in such a way that 2 patients are there for the same day, it is possible, in which case the treatment cost is, you know, not halved but 60% of the total cost. So that way we are getting some more patients. But suppose if you are not able to do tear, but I must say something, Sarwar, that the last 2 years of data are heavily favoring tear. If you look at organizations like the Mass General, they've almost stopped doing TACE because they've completely shifted to tear. Even for the small lesion, they've gone to radiation segmentectomy. For the intermediate lesion, they've gone to standard tear. And for the one with the portal vein thrombus, tear was there anyway. So they've moved to tear. If I have to do an 11 centimeter, like we do, if you have to do it over multiple sessions. And you have to make sure that you do not close your, so do not put a permanent embolic into your hepatic artery so that you can access the hepatic artery a second time or a third time. But always remember that progressively doing more and more TACE becomes more difficult, both technically because the vessels are attenuated, spasm, dissection, also because liver function takes a hit repeatedly if you do TACE. So I know the Koreans do up to 10 times they would do a TACE, right? That applies to a subsegmental TACE. But if you're doing lobar TACE, doing more than twice or thrice is difficult. But still I would break it down. I would do 2 or 3 TACEs. And then if there is a little bit of residual nodule, I would treat it with ablation.
Dr. Shubha, let me supplement to your response that I am the fortunate speaker coming up later on. Maybe I will be putting some light on the answer of Dr. Sarwar that in 11 centimeter tumor in Bangladesh, even we don't have tear, how can we manage it? So let us keep the puzzle for a few minutes, we'll be talking. Thank you.
Thank you. The question session was very enjoyable and well directed. And as we are running out of time, so we should go to our chairpersons. Please, Professor Shafiqul Islam sir, please give some your.
Thank you very much. It was a nice and lively session. Thanks to both of our speakers, Professor Shubro and one from China. Basically, I am a neurosurgeon, so everything I learned here is new for me. I am here just to support them. I am interventional neurosurgeon also. So sometimes I am on the cath lab to be with them in this procedure. So I would just like to congratulate both of you for a wonderful talk. Thank you very much.
Professor Bilal Alam sir.
First of all, I thanks to Professor Salimur Rahman for inviting me as chairperson in this session. It is a very lively and knowing session. I think ACC is a great problem, not only in Bangladesh, in Southeast Asia. And we are very much behind the modern treatment of ACC. I think our second speaker, Professor Shobhra Rai Chaudhuri, he is the pioneer and first person who are initiating the interventional ACC treatment in Bangladesh. First, I think Professor Salim Rahman already stated that Professor Shobhra Rai Chaudhuri first started TACE and RFA and microwave ablation is going on before his arrival. I think so. Professor Momin Khan started it before Professor Shobhra Rai Chaudhuri. I have a realization. I was the principal of Sir Salimullah Medical College and head of the department, Dhaka Medical College. The intervention which is now going on in Bangladesh, TACE, TRE, RFA, microwave ablation, still now, 127 medical colleges in Bangladesh, all the teachers, not students, all the teachers don't know it. First of all, I request the President and Secretary of BSL CTR to introduce all the principals and directors of all medical colleges, private and government medical colleges. What are the intervention you are doing in Bangladesh? You should know them. And you should circulate it. You should advertise it. And probably you are arranging this conference. You should invite at least 127 principal and 127 director of all the medical colleges, private and government medical colleges. If it is done, your conference will be more successful. So I think now I am the controller of examination. I circulate it. I help. I want to help the people who are suffering from ACC. They are not getting the interventional treatment. They are not getting the appropriate treatment. And we should help them by circulating this message that probably all the intervention except transarterial radioembolization is not introduced still now, but all other intervention is available in Bangladesh. Again, I thanks to our two speakers for enriching our knowledge. Thanks to organizer for inviting me here. Thanks all. Thank you.
Thank you, sir. Now, last but not the least, Professor Khan Abul Kalam Azad sir will give some concluding speech.
Thank you. First of all, it was a wonderful morning, and definitely it was a session with full of information. I want to say that one of the pioneers in the treatment of liver disorders, Professor Salimur Rahman, and his team, the effort to treat the liver cancer patients in Bangladesh. And definitely they have gone to a long distance. And also we have got the international collaboration. That is a great news. All the participants, all the speakers from abroad and from the country. As an internist, I find many patients having hepatocellular carcinoma, but most of them, when they come, it is late. And there is no methodical the approach to a patient with liver cancer. And also, one thing I want to emphasize before that is when there is liver cancer, on many occasions we find the association with your B virus. So prevention of this viral transmission is very important to prevent liver cancer. That is very important. And also in Bangladesh, like many other countries, we find many patients are innocent victims of chronic hepatitis B virus infection. So how much we can do for those group of people, that is a question. So how much follow-up they need, what is the screening procedure, what is to be done for them. So that is a very important question and important issue. And the second point is that when there is liver cancer, so it means that whether it is on the top of cirrhosis of liver, what is the functional status of the liver, what are the comorbidities present, how much the patient is capable, how much the patient has gone for the specialist, recommendation. So those are so many questions. But after coming here, after knowing that so many treatment modalities for them, before transplantation, definitely we hope that the best form of liver transplantation will be available in our country, like many other specialized centers. But the thing is that before it is available and acceptable by most of the people, the other form of treatment which are being provided to the patient, huge number of patients, I'm very sure that that will work. And if we can detect this liver cancer very early, so the best form of treatment modality and the surgery, that is the curative hope, and then different types of interventional treatment, what we saw here. So those are very important for the patient and for the specialists. Everybody here present, especially the hepatologists, they should work in collaboration with your interventional radiologists, the oncologists and others. And definitely they should screen the patients for the presence of this hepatocellular carcinoma. So it is a wonderful session. I'd like to congratulate both the speakers from China and from India. So they had a wonderful presentation. We could learn so many things, and if we can continue our, the learning spree in the direction, so we can help our patients in a better way. And I think our future hepatologists who are getting preparation to help the people, I congratulate this BSL CTR that they could, successfully hold the meeting, the second international annual conference, and I'm very much happy and delighted, and so many participants are there. I hope that this meeting will be a success. Thank you very much. Thank you.
Thank you, sir. Thank you, speakers and panelists of this session. Thank you all. We're going to the next scientific session, that is session 4, will be on oncology and radiation therapy treatment in HCC, an underutilized option with huge potential. That will be moderated by Dr. Mohammad Ashraf Hossain Ghazi, Assistant Registrar, Sir Salimullah Medical College. I will hand over to him.
Thanks a lot to Dr. Saad Ahmed Tanmoy. This is Dr. Mohd Asra Shaman Kaji. Assalamu alaikum and good evening. Apa? Roshana.
Attention, please. We have a small token of love, a memento for Dr. Shubhra Roy Choudhury. I'd like to request the chairpersons of that session to come in the dais and president of BSL CTR. The crest will be handed over to Dr. Shubhra Roy Choudhury from President of BSL CTR.
Assalamu alaikum. Good evening. Distinguished participant, dear doctors. You are all now welcome to the fourth session of this second international annual conference of Bangladesh Society for Liver Cancer Treatment and Research. In this session, we will discuss about two important modalities for the treatment of liver cancer. One is radiotherapy and another one is newly emerging immunotherapy. We are very much honored with the presence of two renowned oncologists, one from home and another from abroad. At this stage, I like to request Dr. A.F.M. Kamaluddin sir, Senior Consultant, Clinical Oncology, Leavitt Cancer Hospital and Super Specialty Cancer Center, and Dr. Vamshi Krishna M., Director and Head Medical Oncology and Hematology, AIG Hospital, Hyderabad, to come to dais and take their seat. This session will be chaired by Professor K.M.J. Jackie, Dean, Faculty of Medicine, Sylhet Medical University, and Professor Shapon Chandra Bandopadhyay, Professor and Head of Department, Radiotherapy Department, Sir Solimullah Medical College and Midford Hospital. Chairperson, sirs are requested to come to dais. Thanks a lot, sir. Our first session on radiation therapy. Our topic is radiation therapy treatment in hepatocellular carcinoma, an underutilized option with huge potential. This will be presented by Dr. A.F.M. Kamaluddin sir. I humbly request Dr. A.F.M. Kamaluddin sir to state his delivery.
Bismillahirrahmanirrahim. Good afternoon. Assalamu alaikum, ladies and gentlemen. I am Dr. A.F.M. Kamaluddin. I am working as Associate Professor in National Institute of ENT and also the Senior Consultant in the Leavitt Cancer and Super Specialty Center. Today I am going to talk about radiation therapy treatment in HCC, an underutilized option with huge potential. The word that I missed is in Bangladesh, because it is not underutilized in whole over the world, but in Bangladesh it is very much underutilized. I want to acknowledge to Professor Salimur Rahman and the team because I waited 10 years to make this presentation from 2013 to 23, and finally I get the chance to talk. And it's also an honor that the radiation oncologist is invited in this session. I always love to start my presentation remembering a great person, Professor ABMF Karim, who was a great radiation oncologist. He was the first fellow of Royal College of Radiology from Indo-Pak subcontinent. And he was the emeritus professor in Free University Amsterdam. He was the two-time president of European Cancer Society, author of 7 books and many other things. But the most important thing is he was a man from Bangladesh. We lost him in 2012, but I feel proud that we are from the same country. So first, I want to start an experience of 2013 from where I was waiting for this presentation. A 60-year man came to my room, referred by a nephrologist. In a routine screening, in ultrasonogram, a lesion in his liver was found. He had no symptom. His function of liver was completely okay, but alpha-fetoprotein was 80 and the FNAC proved to be HCC. He came to me, an oncologist at that time, hardly know what to do. And it was a 10.5 centimeter liver lesion. I have done the screening, all the viral marker was negative. So at that time, what I do, I started giving chemotherapy to the patient. telling that you have no cure. Because I discussed about transplant, he was not ready for that. After giving chemotherapy, the lesion was exactly the same size, but the alpha-fetoprotein came down. I felt encouraged. I said, okay, now go to the surgery department. He went to BSMMU, get admitted. You know, and the last day before the surgery, there's a final counseling done. After the counseling, he left the hospital without notice, came back to me, sir, I'm not going to do the surgery. I want to die, but not on the table. So he was so scared. Then I discussed about doing TACE, because at that time TACE was not in our country. And he was not ready to spend that much of money going to overseas. So I looked at the NCCN guideline. It is 2023, but at then 2013, that when the patient is not a candidate for transplant, we can do some non-surgical intervention. So, and look at the guideline that ablation is possible up to 3 centimeter, maybe up to 5 centimeter, but not more than that. But this is a 10 plus centimeter. What to do? So the first thing came to the mind is SBRT, SABRE, a newer technique of radiotherapy where we give ablative days of radiation therapy. Number of fraction is 1 to 5 and the target is outside the cranium. These all interesting machines including high-end linear accelerator, CyberKnife, Tomo, Vero can be used for using SABRE. If you look at this curve, it's a very fairly old curve. From 2000 to 2010, you can see how fast the SABRE became popularized. And if you look at the site, the third common site used for SABRE was liver. And another important thing was that this SABRE can be used for old age comorbid people. In lung cancer study, it was shown that after coming of SABRE, 30% of comorbid old age lung cancer patient got treated. So this SABRE became a good news for comorbid patient, old patient, extreme old patient. Coming back to that patient, you see the lesion on the right lobe, it's a huge lesion. And then we discussed with the patient and we planned our first case of SBRT because at that time I had the opportunity to get some training in Korea and we came back. And we used 5 fraction, 10 gray per fraction, and alternative day we have treated. We have done the 2D, 3D match and CBCT match. After 6 months, there was 60% reduction of the size, which was a big, big surprise for me and all for the patient. But the story is, you know, in HCC is not always very great. So what we did, we waited, and when again the alpha-fetoprotein started rising after 1.5 years, we did the second SABRE on the same patient. And then from 2014 to 2019, the patient survived for more than 5 years, almost 5 years. And I lost the patient in 2019. I lost him, but he taught me that there was some way. So coming back to HCC, I'm sure a full day we had discussed that it is a big killer and we have hardly still all the solution where surgery is the main solution. But majority of the patient is not a surgical candidate. So we have a solution, but we don't have the candidate. In RFA, we have a good solution. Again, there is some restriction of size and location. Already we heard from Dr. Chowdhury about it. Microablation, TACE, and TARE is also some hope. Systemic therapy like sorafenib, now lenvatinib, and now immunotherapy is there, but it has its own limitation of toxicity, both physical and financial. And non-surgical ablative therapy, we have EBRT, thermal technique like RFA and cryotherapy, TACE, and selective internal radiation therapy. So thanks to my previous speaker who has created the ground and told most of the principle of radiation in HCC, because the principle of tear and SBRT is almost the same. The only difference is here, there the radiation comes from inside and here the radiation goes from outside. But it's the same principle. We want to squeeze the tumor, we want to kill the tumor, we want to ablate the part of the liver, but saving the remaining part of the liver. There our benefit is we can deal with any size of tumor provided the remaining liver is enough to take care of your normal functioning life. So we oncologists are not that much courageous, so we always love to take the support of guideline. We don't want to cross the guideline. So for us, our Mecca is ASTRO, American Society of Radiation Oncology. ASTRO published a wonderful guideline on external radiation therapy from primary liver cancer. It was published in 2022. They have addressed 5 questions. If you look at the question, what is the role of external beam radiotherapy in definitive non-transplant and palliative setting of HCC? The answer they have given is 2 strong and 3 conditional. For patients with liver confined HCC who are not candidate for curative options like surgery or thermal ablation, and for whom catheter-based therapies are being considered, EBRT is recommended as a potential first-line single therapy option. Number 2, for patient with liver confined multifocal and or unresectable HCC, EBRT alone or sequential with other catheter-based therapies is conditionally recommended. Number 3, for patient with liver confined HCC who had an incomplete response to thermal ablation or TACE, EBRT is recommended as a consolidative treatment option. For patient with locally recurrent HCC after surgery, thermal ablation or catheter-based therapies, EBRT is recommended as a salvage treatment options. So it is another, again, both are the strong recommendation. And for patient with liver confined HCC with macrovascular invasion, EBRT is conditionally recommended alone or sequenced with systemic therapy or catheter-based therapies. It is a conditional recommendation. And for patient with symptomatic locally advanced and or metastatic HCC, palliative hypofractionated EBRT directed to liver and or macrovascular tumor thrombus is conditionally recommended and alone or sequenced with systemic therapy or catheter-based therapies. So next question, what is the role of EBRT in neoadjuvant setting before surgical resection or orthotopic liver transplant for HCC? So there is 2 conditional recommendation that to bridge the time between transplant and the waiting time, we can use EBRT. Third question is, in patient receiving EBRT for HCC, what are the preferred technique, fractionation regimes and recommended OAR constraint? Here, most of the recommendation is hypofractionated or ultra-hypofractionated radiotherapy like SABR is the best option. And different dose fractionation is recommended. Question number 4, what is the role of EBRT in definitive and adjuvant setting in HCC? Again, strong recommendation is for patient with unresectable intrahepatic cancer, induction chemotherapy followed by consolidation with EBRT alone or in combination with chemotherapy is recommended. And conditionally, we can use for patient with IHC who underwent curative surgical resection and have high risk feature adjuvant EBRT with concurrent chemotherapy alone or sequential after systemic chemotherapy is conditionally recommended. The last question, in patient receiving EBRT, what are the preferred technique? Again, ultra-hypofractionation is the recommendation. So those are the guidelines published in 2023. Like Dr. Chaudhary, what is fresh from the oven? It is the fresh from the oven is 2023 publication, a huge noise-making paper that in recurrent HCC, if you incorporate SBRT with sorafenib, it gives better survival, DFS, OS, compared to sorafenib alone. We oncologists now never stop talking unless immunotherapy is discussed because it is the fashion, it is the fancy, and it is the hope. So it is a small series that match propensity analysis of small series have shown that immunotherapy combined with SBRT is promising. And the curve is quite separate. Even the number of patients is very small. So in the whole world, so many studies are going on with SBRT and immunotherapy, including HCC. Maybe we will get some good news very soon.
And what about sequential use of immunotherapy? Is a phase 1 trial that SBRT followed by Nivo plus EP or Nivo alone has shown some promise. So the take-home message is HCC is a challenging problem for all physicians. Surgery offers a long-term survival and potential cure, but most patients are not surgical candidates. NCC ASTRO guideline recommends wide range of area for role of radiotherapy in HCC. Radiotherapy may be used in definitive, palliative, neoadjuvant, and adjuvant setup in HCC treatment. Local tumoral control following SBRT is excellent, is more than 90%. SBRT can be offered safely to elderly and comorbid patients. SBRT for HCC was successfully practiced in Bangladesh in 2013 with a wonderful experience. Benefit of SBRT treatment to HCC can be spread to more patients with collaboration from other colleagues. So if you look at the HCC treatment in team of Bangladesh, you will see hepatologists there, you see hepatobiliary surgeon there, you see interventional radiologists there, you see medical oncologists, pathologists, and nurses. The missing person is me, the radiation oncologist. Why? Because I can do things you cannot. You can do things I cannot. But together we can do great things. So the question is, can we bring hope to this patient? Can we do it? I think yes, we can. We did in 1971. We fought for the country and we got this flag. We got this flower and we got this monument. In 1952, this nation fought for their language and the only country in the whole world who got their mother tongue by fighting. And we have an interesting person who can dare to say that he wants to send poverty to the museum. And we have a wonderful cricket team. They are not the world champion, but they have the habit of beating any team in the world. So I think we can. Thank you very much.
Thank you, sir, for your excellent experience-based and informative speech. It enriches our knowledge a lot. Thank you, sir. Let's say a big clap for sir. Our next session is on immunotherapy in HCC. Dr. Bhamish Krishna M. sir is requested to kindly come to dais and deliver his speech. Dr. Bhamshi Krishna M.
Good afternoon and thank you. I thank the organizers of the Bangladesh Liver Cancer Society. I also thank all my previous speakers who have set the stage for me to speak on immunotherapy in HCC. Immunotherapy seems to be like a red flag in front of a bull. People seem to malign immunotherapy for all sorts of reasons. I'm here to try and explain where immunotherapy works, what are the advantages, and of course, there are certain disadvantages whenever we talk of any treatment, which also I will try to highlight. I'll talk about the staging, I'll discuss some cases that we have done in our institute, also talk of where the data has come from, the I Am Brave study, discuss whether we have other options of therapy, and then decide what we can do. So we know that India and Bangladesh are both in the society where the incidence of cancer is certainly lower than the West, but it is increasing. And our population is such that even with a lower population, lower incidence, we still have a huge number of patients. Speaking of HCC, it will be around 4th or 5th among the GI cancers. We are seeing an increasing number of such patients in our country as well, and I'm sure here also the numbers are increasing. When we talk of treatment, this is something that is drummed into us right from the beginning, the BCLC, and it has stood the test of time. Traditionally, where all medical oncologists used to come was this advanced stage C, where you had extrahepatic disease, you had portal invasion, in the presence of a preserved liver function and good performance status. Those two words are very crucial. Preserved liver function and good performance status, because that's where you can treat. Anything beyond that, that is D, is really not somewhere we have good options of. What has changed in the last 3-4 years is not only that we have a good treatment option for the BCLC-C, we are also seeing the same drugs moving into the BCLC-B, that is the multi-centric disease. And that's also something where we have to include systemic therapy, because all our local therapies do not work in all those cases. I'm very happy to note that everyone has been talking of a tumor board, and at least I believe that the tumor board is the way to go ahead. And it's just not a belief. There is a paper which said that if you have patients being treated in an MDT, the upper line, that's your survival curve. You know, as oncologists, we only talk of survival curves, and there's a survival curve which says that if you treat the patient in an MDT, it is better than treating in a non-MDT setting. In our institute, we are having an MDT which includes a radiation oncologist, which includes the pathologist and everybody else that has been included, and includes a surgeon. Our aim is to even bring those cases which are early as well as advanced and discuss what is the optimum option. And it's very interesting that sometimes there are intervention radiology colleagues will say, okay, this tumor has some vessel involvement, we won't be able to do TACE. Immediately we are very sure that we have a SBRT which can be given at that point. And we are doing that on a routine basis now. Plus there are certain cases where the intervention radiologist is a little hesitant, you have multiple lesions. That's when we step in and say, okay, let's give some systemic therapy, or let's do one TACE, wait, give systemic, radiate the remaining liver. So there are plenty of options that are come out once you start talking to each other across the table. So this is important, and I'm very happy that that's the same message which I think all speakers have been giving since the morning. So this is one of our patients, a 78-year-old gentleman. He's actually a doctor. So 78 years old, but pretty fit guy, known case of HCC. He had undergone a resection in 2018. So the 2 into 2 centimeter, left lobe segment 3 extending into segment 4 and 5, wide excision done, following which regular imaging was done, and each time we did a CT, the MRI, everything was normal till April 2022. Then in June, he again came back saying that, look, your scan is fine, but I am not feeling good. I am losing weight. And then we did a AFP, and to our surprise, it rocketed up to more than 6 lakhs. Then again he was evaluated with scans. We was very good performance status, child POG A6, upper endoscopy done, no varices, and as expected, it showed plenty of disease. This was the scan. Now this was a large lesion in the right caudate lobe. We also did a scan which showed some nodes. Now as a habit, I mean it's not a recommendation, but it is something that we often do. We did a PET CT scan, and we found that he also had lung nodules. So frankly, extrahepatic disease, PCLC stage C. What were the options? Now till 4-5 years back, all we would do was sorafenib, lenvatinib, and a whole bunch of medicines, some of which were unfortunately not working. You know, we had hopes of immunotherapy with nivolumab and pembrolizumab. In the first line, both of them failed. So our options used to be sorafenib or lenvatinib, until of course now we have these new medications, that is atezolizumab, bevacizumab, and then the new drug, that is the durva and tremelimumab. Now durvalumab is available in India, tremelimumab is going to be launched. Yesterday only DCJ has given approval for the launch, so it should be launched in a couple of months. Of course, for patients who cannot afford, we have these two. Fortunately, this gentleman could afford the treatment and he was willing for the treatment. So we went ahead and treated him with atezobev. This was the treatment that he received starting in July 2022, went on till actually May 2022. This is the AFP from more than 6 lakhs to more than 3 lakhs, then 30,340 within a span of 4-5 months. So this is a dramatic response that we noted in him. We continued giving him. Unfortunately, in May this year, after around 10 to 11 months of treatment, he has progressed. But these are the scans. Again, you just look at the first scan on the right, that on the extreme left, that's an ugly looking tumor. You have 2 big lesions, the entire liver looks studded, and with the IOBEV, significant reduction. The third one was in December, again a significant reduction. Now in May, again there have been new lesions detected. Again in the liver, some of the lung lesions have worsened. So 10 to 11 months survival at this point, but very fit, no side effects. He actually used to travel almost 600 kilometers to come to Hyderabad for the treatment. So that's the kind of treatment that we can offer. Less of side effects, and more importantly, good results on radiology as well, which was not seen. So why combine this combination? What is the benefit of using this combination of atezolizumab and bevacizumab? Now, atezolizumab is a PD-L1 inhibitor. It is a kind of an immunotherapy. Now, immunotherapy is very interesting. This is how I always explain to my patients. Look, cancer goes and kills the cell, the cancer cell itself. But immunotherapy makes your immune cell go and kill it. So you essentially block the PD-1, PD-L1 axis, make your T cells active, and those T cells will go and attack your cancer cells. So in a way, it is utilizing your own body cells. That is the reason why these side effects are less. That is also the reason why the major side effects are actually a whole new bunch of immune related effects, which we are of course learning to manage now. Along with that, if you add the bevacizumab, now bevacizumab is very important because it has anti-VEGF activity. And remember, HCC works a lot on angiogenesis. So this combination of atezolizumab and bevacizumab targets two different pathways, and it helps both of them. So that's why this combination was started. There were some phase 2 and phase 1 supporting studies which showed that it worked, and that led to this study. Now the IMbrave 150, again for those of us who are in medical oncology, we keep dealing with IO. The names are like this. So when you have 1, it means first line. So IMbrave is, IM is all the immunotherapy for atezolizumab. So IMbrave 150 means first line HCC. So that 50 means HCC. So IMbrave 150 design, simple study, very straightforward. You compared atezolizumab, bevacizumab versus sorafenib. Around 500 patients. You used all patients including those who had macrovascular invasion and extrahepatic spread. You stratified according to the AFP. So you included basically all the high volume and high risk patients. This group of patients were actually not included in your lenvatinib study, which was a criticism of that study. But here all of them were included. Baseline characteristics, important part to note is that all the patients were Child-Pugh A, with the exception of maybe one odd patient who was Child-Pugh B. This is very important. In the study, only Child-Pugh A patients have been included. So this we have to take care that we are using Child-Pugh A. When we talk of the BCLC stage, you had stage A in most of the, very few patients, mostly it was B and C. So B and A together were around 20%, which is also significant. Was, as I told you in the beginning, BCLC B is somewhere where you can use these medications. Coming to the etiology, non-viral was only 30%, mostly viral. In India, as I believe here also, most of our patients are actually NASH related. It's more NFLD related rather than viral. So again, tells you that it can be used in all the settings. So looking at the PFS. Now PFS on paper doesn't look great. It's 6.8 versus 4.3. But in the context of HCC, BCLC-C, that's actually a significant improvement. So 2.6 months improvement with a good hazard ratio. Again, for non-oncologists, we look at only the gross number. Remember, this is a median. And what we are looking at is the hazard ratio, which tells you what is the chance of improvement. We also look at the confidence intervals, 0.53 to 0.81, which again tells you that these drugs have a very good response. It is not by chance alone. So that's essentially what it tells you. When looked at the overall survival, again, oncologists, we love talking of overall survival because that's ultimately what we need. The initial study, the initial update was around 0.58 hazard ratio, not reached in this arm versus 13 months in the sorafenib arm. When the updated results came, it showed an OS of 19.2 versus 13.4 months. Now 19.2, remember, is 1.6 years. It is very large in the context of a HCC stage 4 or a HCC BCLC-C. We are not talking of early liver cancers here. We are not talking of curative setting. We are talking of a setting wherein the HCC-C, BCLC-C, and there 19.2 months is pretty much unheard of. So 19.2 versus 12.4 with a very good hazard ratio. Now remember, I talked about subgroups. This is always exploratory. The paper cannot make so many patients and try to look at individual numbers. But when you looked at the exploratory subgroup analysis, it seems to work everywhere. All the subgroups which I had shown you before, it works in all. Possibly the only exception would be the non-viral etiology where the data is still out. But other than that, it seems to work everywhere. More importantly for me, look at the overall response rate. Now when I talk overall response rate, I am talking of radiological response. With sorafenib, we hardly see that. It's around 10% even in the study. In the original paper also, overall response rate is around that much. Mostly we would see stable disease. Patient is doing okay, it's just continuing. But here with the immunotherapy combination, we are seeing an overall response rate of 30%. And we are also seeing a disease control rate of more than 74%, which is very significant. Was this because patients could not get further therapy or they got further therapy? That's the usual criticism. In this trial, second line therapy was received by 50% of patients on sorafenib, less in the atezo arm. So that tells you that despite getting more therapy, sorafenib arm still could not get the overall survival. That's point number one. Point number two, in HCC, your first attempt is possibly your best attempt. You know, some people say, no, you don't give in the first line, give it in the second line, you might get equal results. It's not like that. It's better to use your best weapon upfront. Now also, the side effect profile. We all know about sorafenib, we have handled it. It causes significant side effects like diarrhea and hand-foot syndrome. With the atezo-bev, these two side effects are significantly lower. The other side effects which we do see are the IR-related side effects, which are all manageable. Is there any other option? You know, that's exactly the question which anyone would want to know. Why talk of such expensive drugs alone? Do we have other options? Well, this was the REFLECT study for lenvatinib. Now remember, in the lenvatinib, they excluded patients with bile duct invasion, excluded patients with macrovascular involvement and liver involvement more than 50%. These were included in your atezo trial. In REFLECT, originally when the paper came out, we were very excited. You know, you're having a PFS doubled, looked easy. But then the OS, which was a primary endpoint, was not met. And that was a bit of a letdown. Even in numbers, only 13.6 versus 12.5. Remember, in the atezo trial I showed you, sorafenib had an overall survival of 13 months. So sorafenib is doing what it's supposed to do. It did 12.5 here, 13 there. It is doing what it's supposed to do. Lenvatinib could not translate into the overall survival. Next is another paper which we talk of a lot. This is the Himalaya study, and I am sure in India at least we're going to talk a lot about this because it's going to be launched in India. Now Himalaya used a different model. They didn't use only immunotherapy and anti-VEGF. They used immunotherapy with another immunotherapy, which targeted a CTLA, another molecule. So they used T300, which is the dose of tremelimumab, single dose, with durvalumab versus only durvalumab versus only sorafenib. Again, I'll show you the results in a further slide. The other study which came about was known as the COSMIC. Now, cabozantinib is a drug we are all aware of. It works in second line. So why not combine that with atezolizumab and check against sorafenib? So that's the COSMIC 312. And then the LEAP study. Lenvatinib works. Pembrolizumab is a good drug. This combination is good. Why not try that? So lenvatinib plus pembro versus lenvatinib. This was the third study. Now let me show you all the results. Now this was the LEAP 2. Overall survival not met. PFS not met. So you are adding an immuno to another drug. It is not better than the drug alone. That's what this basically showed. So for me, this is the important slide. When you look at all the trials above, you have lenvatinib versus sorafenib, atezo-bev versus sorafenib, durva-tremi versus sorafenib, cabo-atezo versus sorafenib. So sorafenib using as your standard of care, all these studies, when you look at the results, lenvatinib, PFS is significantly better, OS is same. At this point, what will I decide? If I have to give a drug, let me give lenvatinib. At least for us, the cost of lenvatinib, sorafenib is almost the same. It's slightly higher for lenvatinib, so wherever possible, I give lenvatinib. I believe we have generics here as well for both of them, so possibly the costs are same. If the costs are slightly same, then lenvatinib would be my preferred choice. But where it is possible to give, look at the atezo-bev and durva-tremi. Atezo-bev gives you the PFS advantage, gives you the overall survival advantage, gives you the best overall response rate of 27%. Durva-tremi gives you only an overall survival, does not give you the PFS. The LEAP study, though it gave you longer numerical periods, again does not give you significant overall or PFS advantage. So for me, after this study, the top line still remains atezolizumab bevacizumab combination because it gives you PFS and OS advantage. Now this was one more study which came last year. It was a tislelizumab, one more immunotherapy, which gives you a non-inferiority to sorafenib. So we'll be hearing more about this, I suspect. The next thing we talk of, this was all BCLC-C, where the numbers are not so great. But we need to also focus on the intermediate stage. Now we have been talking about intermediate stage. Remember, intermediate stage is anything from that bottom where you have one large liver lesion, the 10.5 centimeter which we have been talking of, to one big lesion with other lesion, to one lesion with multiple other lesions, to multiple small lesions in the liver. All these come under BCLC-B. Again, we have heard this before. As the number and the size keeps increasing, it essentially is again a palliative treatment. Even if you do TACE, even if you do TARE, whatever we do, none of them are curative. Again, you're having a median PFS there of 2.5 to 3 years. They do relapse, and at that point, many of them are not eligible for your systemic therapy because by then they would have exhausted. So if you have especially something like the last liver, where the liver is studded with lesions and no extrahepatic spread, still that would be the case where systemic therapy is the drug of choice. This was one patient we saw last year, a 61-year-old gentleman, abdominal pain, non-specific, multiple liver lesions, around 4 liver lesions in multiple different lobes, largest to 6 centimeter, total size around 15 centimeter. So early CLD, CPS-A, BCLC-B. A lot of discussion in MDT. There was some thought of whether to give for a multi-staged TACE, whether to put him for a transplant. So what we did was we started him on the chemotherapy, on the immunotherapy, atezo-bev, and after 3 months there was a complete response. 3 months later, further response. Again, images are what we always like looking at. So that is the 2 lesions and this is the liver after 5 months. Almost complete response. Now we do see some of this in local directed therapies. So this is why what we are looking at is actually combining therapies now. You don't just go with one, you try to combine modalities of therapy to give you better results. So for me, at least in BCLC-C and maybe even coming forth, the Game of Thrones, for those who can recognize the TV series, the winner is atezo-bev. Durvalumab is there, lenvatinib for those who cannot afford it, but all the rest, the lenva pembro, your cabo atezo, all have as of now not been working. So this was our experience from our institute, where we partnered with the hepatology department. Both of us combined our data and published. We had a total of 67 patients to whom atezo-bev was given. Now in this, the etiology again, NASH was 55% of patients. So like I said, most of our patients are NASH. HBV, HCV around 37%. Baseline AFP 720. BCLC staging, stage C was there in 50 patients. B in 9% of patients. Now childhood C was still included. Now this is something which I would not advocate, but again this was a real world study. So we did have some patients who were otherwise fit, who were willing for the treatment, who said no, we want to try it even though it is in BCLC C and in childhood D. So these patients, when we looked at all our responses, first the good part, the childhood A responses, you had a CR rate of around 12%. We had a partial remission of 26%. Overall disease control rate was around 68% for patients in childhood A. Childhood A, sorry, was 79%, childhood B was 68%. But something which we all remember, childhood C, if you can look at that small column of childhood C, all 6 patients progressed. Basically, none of them could tolerate the treatment. They went into liver dysfunction and they had a progression of disease. So it was a learning experience for us. Childhood C, don't do anything. Do not give immunotherapy. That's the lesson which we learned, which has to be also taken. Childhood B, otherwise fit, B7, yes, you can still use it. Our results showing childhood A, the overall survival was around 22 months. Childhood B is around 9 months. So again telling you that real life evidence, these drugs do work, because you know whenever we present or talk of the data, the first question asked is what about us? This is not drugs for India, it is not drugs meant for our country. These are drugs meant only for abroad, and that is not the case. When used judiciously, these drugs work quite well. Of course, we need to be selective in whom we give it and of course discuss the options and everything, but wherever it is given in the right patient, it works very well. What about second line? Again, just a short thing. We know right now you have cabozantinib, nivolumab, pembrolizumab and all these other drugs. Nivolumab did not work, it's been actually withdrawn. Pembrolizumab has the same results as nivolumab, but for some reason the FDA decides to continue it, I don't know why. Personally, we are not using either of those. My thought is to use the immuno in the first line wherever feasible and not use it in the second line. Preferably in the first line is where I would use it. So again, the future, and it is becoming the present. You know, when I wrote this slide 6 months back, after that already one paper is out and one more is going to be out, is going to be the use of immuno in the early stage adjuvant setting. When I say adjuvant, I mean patient where you have completed your surgical resection, or you have given a liver directed therapy and then give treatment, or in the intermediate stage where you are combining this with the TACE with durvalumab or TACE with lenvatinib pembrolizumab. Emerald 2 is going to be read out soon, And we already had results from the IMBF 050. This was read out in April of this year, and that showed a significant improvement in the relapse-free survival. So again, would I do it for all patients? At this point, no. But certainly, where we know there is a high risk of relapse, you have a resection with maybe a 8 centimeter size tumor, you had very high AFP to begin with, possibly those are the patients where I would push and I would suggest that we add a immunotherapy as an adjuvant therapy. So that is where we are headed to, and certainly the entire spectrum is now going for a combined modality therapy right from early stages. Immunotherapy and systemic therapy is no longer the domain of only the BCLCC, but we need to bring it ahead for improving the overall results. So if I can summarize, these are exciting times in HCC. At least in BCLCC, first line is as of now atezo-bev. Durva-tremi is a good drug, we will see how it evolves. If patient cannot take IO, give lenvatinib. Second line, if you have not used IO in the first line, still atezo-bev remains the first choice. Otherwise, you have your cabo, ragoa, whatever you want. I personally prefer cabozantinib, but people are free to use. And that's my lecture for today. I'll be happy to take any questions.
Thank you, sir. Thanks a lot for your nice and informative speech. Please take your seat, sir. Now this session is open for all. If you have any query or question, you may ask to our learned speaker. Any query or question? Now we are going to
resource limited settings.
Nivolumab
and with lenvatinib in resource limited settings.
So if it is resource limited, nivolumab I think costs almost as much as atezo-bev. So it's possibly easier to just use the atezo-bev rather than give nivolumab. That's point number one. Number two, nivolumab has not worked in HCC. So I wouldn't do that. So as of now, if at all I want to use nivolumab in very low dose or something, that is something it is still at a trial level, I wouldn't recommend it as a routine usage. So at least in India, the cost of Nivo is almost the same as atezo. So I prefer giving atezo rather than
But in Bangladesh, it is much lesser.
I am not sure of that. I think so because as far as I am aware, the cost of nivolumab is hardly 10-20% lower than the international price. But again, I am not sure of that.
Okay.
But given a choice, I wouldn't, because even at the generic level, nivolumab is expensive.
Okay.
I wouldn't combine.
What about the clinical outcome? Is the similar or?
So it's not as good. The nivolumab drugs have failed, both in the first line as well in second line. There is no overall survival advantage.
Okay, thank you, sir.
So just I want to supplement that Nivo low dose was successful in head and neck. It was not successful in HCC. So taking the call of low dose Nivo, a big noise in India, it is not for all site.
Yeah.
It was only for HCC. And recurrent HCC, metastatic HCC, head and neck cancer.
Head and neck cancer.
So we should not take the call for all sides, especially in HCC. HCC, and as he said, is failed. So there is no rationale till now to try Nivo without a level 1 evidence in HCC.
Absolutely agreed. We are trying low dose Nivo in other settings. We are trying it, but again, in RCC, it is the only place where I have seen it works. Other places, I am not very confident.
Thank you very much, both the speakers, for very nice deliberation and a very new one. We are new with this system. Our doctors, we ourselves also not very accustomed. As far I have marked in your first case presentation, the case was a very advanced case. Very advanced cases of malignancy was very advanced, but liver function was very good. So you prescribed immunotherapy. But we get the cases, the disease is advanced, but patient is also not in a good condition in respect of liver disease. Can we compromise this situation and adjust the immunotherapy? Eh?
So honestly, like I showed you, wherever we did that, again in the same hope like you asked, it didn't work. So as of now, if performance status is poor because of liver dysfunction, we would actually give 15 days, give him some liver supportive treatment, get his function improve, and then try one of these drugs. If it is bad, if it is child-pug C irrespective, we just tell them to take best supportive care. At this point, child-pug C, the treatment remains best supportive care. Even lenvatinib doesn't work, nothing works in that scenario, unfortunately.
Thank you, sir. Dear participant, now time for speech from our panel of experts. At the very beginning, I like to request Professor K.M.J. Jackie sir, ex-Dean, Faculty of Medicine, Sylhet Medical University, to deliver his speech.
Hello. Thank you very much for giving me the chance to chair this session. In this session, we actually come across with very new type of treatment in HCC. The immunotherapeutic treatment of HCC is available in Bangladesh. In fact, some of the drugs are also produced by the Bangladeshi company. But radiotherapy is absolutely new, and we actually do not know what to do with radiotherapy in HCC. So new concept has come regarding the treatment of HCC. We should be aware of this. Thank you.
Thank you, sir. Now, Professor Shapon Chandra Bandyopadhyay sir is requested to deliver his speech.
Minor correction, Shapon Bandyopadhyay, not Chandru. Thank you, honorable organizing part, especially Professor Salimur Rahman and Dr. Fazol, one of my colleagues from Salimullah Medical College Hospital. Actually, the fight against HCC is a multi-step procedure, and in order to synchronize whole of the fighting weapons, we need MDT, as always it has been discussed and said. Unfortunately, we are not very coordinating in our everyday practice or everyday facing patients. This type of conference focused on always what you do in your earlier phase of treatment and what in an advanced occasion. Unfortunately, the association of B virus and following up the patients who are transforming from pre-cirrhotic state to cirrhotic and sometimes to HCC, that is a preventable measure, and our patients are very reluctant to undergo screening test, and that may cut down the number of HCC patients, especially in a very advanced stage. Hopefully, not few companies, that it was said by some of my colleagues, a lot of immunotherapy molecules, including TKIs, are all available in Bangladesh. Radiation facilities bit limited, confined to the city of Dhaka or somewhere. That is why I do think what was focused by Professor, Dr. Kamal, that the radiation facilities to address hepatocellular in the occasions where no TKI, no TACE, no catheter, there is a hope with hypofractionated way. That is the limitation of facilities, I think. And one of the moments what I talk in every moment, incorporation of oncology in an undergraduate level may ventilate all of the options of oncological management, including hepatocellular carcinoma. Then the whole tools will be coming forward, and the MDT will be much more effective and incorporative. We need inclusive form of management, not excluding one of the specialization from other. Again, hats up to the organizations who brought only hepatocellular carcinoma as a single part of management by your society. Thank you so much.
Thank you, sir. Thank you for your valuable comment. Now this is time for handover of memento. I like to request President BSLCATR. Now I like to request our chairperson, sir, to hand over the memento to our foreign delegate, Dr. Bamshi Krishna M. Thanks to all. Thank you, sir. Thanks to all. This is the time for lunch break and prayer. Distinguished, sir, you are all requested to attend for lunch at Podna, Shurma, and Meghna Lounge at first floor. Please take your token for lunch.